Welcome to Lecture 1 of our 5-part pharmacology series. This first lecture builds the vocabulary foundation you'll use for everything that follows. By the end of the series, you will be able to identify drug classes, understand how drugs move through the body, tell prescription from over-the-counter products, read controlled substance rules, and recognize commonly prescribed medications. Today we start at the very beginning. We will define what pharmacology actually is, look at how drugs are named, describe what drugs do inside the body when they help and when they cause problems, learn the key terms you will hear every day in a clinical setting, and clarify exactly where the medical assistant fits into safe medication practice. Keep in mind that as medical assistants, you will not prescribe or diagnose, but you will be one of the most important safety checks between the provider and the patient. You will document medications, prepare and in many states administer them under supervision, and reinforce what the provider has taught the patient. That means the language in this lecture is not just academic, it's the language you will use to keep patients safe. Here are the 5 things you should be able to do by the end of this lecture. First, define pharmacology and use the core terminology correctly because every later topic depends on shared vocabulary. Second, distinguish the major branches of pharmacology, such as pharmacokinetics and pharmacodynamics, and know the basic sources drugs come from. Third, tell apart the 3 ways a single drug is named: its chemical name, its generic name, and its brand name, since confusing these is a common and dangerous error. Fourth, describe the full range of drug effects, from the helpful therapeutic effect to side effects, more serious adverse reactions, and true allergic responses, because recognizing the difference can protect a patient. Fifth, explain where you as a medical assistant fit into safe medication practice from a legal, ethical, and safety standpoint. Notice that these outcomes move from words to naming to actions to your professional responsibility. As we go through the slides, try to connect each new term back to a real task you will perform in the clinic, such as rooming a patient, updating a medication list, or reinforcing instructions the provider gave. That connection is what turns memorized definitions into safe practices. Let's start with the word itself. Pharmacology is the study of drugs and how they interact with living systems. That includes how a drug affects the body and, just as importantly, how the body handles the drug. A drug, in the broadest sense, is any chemical substance that produces a change in a biological function. That definition is wide on purpose. It covers prescription medications, over-the-counter products, and even substances like caffeine. So why does this matter to you specifically as an MA? Look at the right side of the slide. At nearly every patient visit, you will record and update the medication list, and accuracy there prevents dangerous interactions later. In many states, you will prepare and administer medications under the supervision of a provider, which means you must understand what you're handling. You will also reinforce the provider's instructions, translating clinical language into something the patient can actually follow at home. And finally, shared vocabulary is what lets you communicate clearly and quickly with providers, nurses, and pharmacy staff. When a pharmacy calls with a question about a prescription, you need to understand the terms they use. So pharmacology is not an abstract science course. It's the working language of everyday patient care, and building it correctly now will make every clinical task safer and smoother. Pharmacology is a large field, so we break it into branches. You don't need to master all of these today, but you should recognize the 4 main ones and what each covers. The first 2 are a matched pair, so learn them together. Pharmacokinetics is what the body does to the drug. Think of the drug moving through the body, being absorbed, distributed to tissues, broken down or metabolized, and finally excreted or removed. Pharmacodynamics is the mirror image, what the drug does to the body, meaning its mechanism of action and the effects it produces at the site where it works. A simple memory trick is kinetics equals movement, dynamics equals action. The third branch is pharmacotherapeutics, which is the practical use of drugs to prevent, treat, or diagnose disease in actual patients. This is the branch closest to daily clinical work. The fourth is toxicology, the study of harmful effects, including overdose and poisoning. Toxicology matters because the line between a helpful dose and a harmful one can be very narrow for some drugs. As you move through this series, we will spend a full lecture on pharmacokinetics later because it underlies dosing and timing. For now, just anchor these four names. When you hear a provider mention how a drug is metabolized, you will know that's kinetics. When they describe how it works, that's dynamics. Where do drugs actually come from? Historically and today, drug substances are derived from five broad sources, and it helps to have an example for each. The first is plant sources. Many classic drugs began as plant extracts. Digitalis, which is used for certain health conditions, comes from the foxglove plant, and morphine comes from the opium poppy. The second is animal source. Insulin and heparin were originally obtained from animal tissue, though many are now made by other means. The third is mineral sources, which includes agents such as iron and magnesium that supply elements the body needs. The fourth is synthetic sources, meaning the drug is built entirely in a laboratory. Many antibiotics and a great deal of modern medicine fall here because synthesis gives precise control over purity and supply. The fifth and fastest growing source is biologic products. These are engineered from living cells and include vaccines and monoclonal antibodies, which are large, complex molecules that target disease very specifically. You do not need to memorize long lists of examples. The takeaway is that the medications a patient hands you can trace back to very different origins, and that origin can affect how the drug is stored, prepared, and administered. Biologics, in particular, often have special storage and handling requirements, so you will learn to follow carefully. This is one of the most practical and useful slides in the lecture because a single drug carries three different names, and mixing them up causes real errors. Start on the left. The chemical name describes the exact molecular structure. It's a long, highly technical word, and you will almost never use it in the clinic, but it exists in the scientific record. The generic name is the official, non-proprietary name. It is written in lowercase, it stays consistent worldwide, and it's the name you should chart on the medication list because it does not change from manufacturer to manufacturer. The brand name is the manufacturer's trademark name. It's capitalized, and the same generic drug can appear under several different brand names, and even different brand names in different countries. Look at the example on the right using a medication everyone knows. The chemical name is a long structural description, which I'm not even going to try to pronounce. The generic name is acetaminophen. The brand name most people recognize is Tylenol. Same drug, three different names. Here's why it's a safety issue. A patient may tell you they take Tylenol while also taking a combination cold product that already contains acetaminophen. And now they're getting a double dose without even realizing it. Because the generic name stays constant, charting the generic is the safest habit. When in doubt, confirm both the brand the patient says and the generic underneath it. That single habit prevents duplicate therapy and dosing errors. Now we turn to what drugs actually do inside the body, and we start with the good news, the effect we want. The therapeutic effect is the desired beneficial response a drug is given to produce. It's the whole reason the drug is prescribed in the first place. Two supporting terms belong here. The indication is the reason a drug is prescribed, the condition it is meant to address. The mechanism of action is how the drug produces that effect at the cellular or system level. And notice the third point because it becomes a theme for the entire series. The right therapeutic effect depends on the right dose, the right route, and the right timing. Give too little and you may see no benefit. Give it by the wrong route and it may not work at all. Look at the examples on the right, which also preview how drug classes are named. An antihypertensive lowers blood pressure. An analgesic relieves pain. An antibiotic stops or slows bacterial growth. An antipyretic reduces fever. Notice the pattern in those terms. The prefix or root often tells you what the drug is meant to do. Anti means against, so antihypertensive works against high blood pressure, and antipyretic works against fever. Learning to read those word parts will help you predict a drug's purpose even when you've never seen it before, which is a skill we will build on in the next lecture on drug classifications. Not every effect a drug produces is one that we want, and knowing the difference between these three terms can protect a patient. Move from left to right in order of concern. A side effect is a predictable and usually mild effect beyond the intended one. It's often expected and listed on the label. A classic example is drowsiness from an antihistamine. The patient still gets the benefit, but there's an extra effect along for the ride. Next is an adverse reaction. This is a harmful, unintended response that may be serious and can require medical attention. Adverse reactions are more concerning than ordinary side effects and always deserve documentation and provider awareness. The third term is an allergic reaction, which is different in kind, not just degree. An allergic reaction is an immune response to the drug. It can range from a mild rash to life-threatening anaphylaxis, which is a medical emergency. Here's the practical point for your role as an MA. When a patient reports a reaction, part of your job is to gather clear information and document it accurately, including exactly what happened and how severe it was, so the provider can decide what to do. Do not dismiss a reported reaction as just a side effect. Report what the patient tells you and let the provider make the clinical judgment. Accurate allergy documentation in the chart is one of the most important safety safeguards you contribute to because it prevents that drug from being given again by mistake. These three word pairs come up constantly, and each pair contains two terms that sound similar but mean different things. Getting them straight now will save you confusion later. First, dose versus dosage. A dose is the amount of a drug given at one single time, such as one tablet. Dosage is the complete regimen, meaning the amount plus how often it is taken plus how long it is continued. So one tablet is a dose, but one tablet twice a day for 10 days is a dosage. Second, indication versus contraindication. An indication is a reason to use a drug, the condition it treats. Contraindication is the opposite, a specific reason the drug must not be used in a particular patient because it would be unsafe. So, for example, a certain drug might be contraindicated in pregnancy or in someone with a known allergy. Contraindications are safety stop signs, and you'll see them flagged in drug references and in the medical record. Third, potency versus efficacy. These are easy to blur. Potency refers to how much drug is needed to produce an effect. A more potent drug works at a smaller amount. Efficacy refers to how large an effect the drug is capable of producing at all. A drug can be very potent but have limited efficacy, or the reverse. You do not need to make dosing decisions using these terms, but you will hear providers and drug references use them, and understanding them keeps you a competent partner in the conversation. When you need medication information, where should you look? The rule is simple. Always verify with an authoritative source, never with a random website or from memory alone. Here are 4 reliable options you can actually use. First, the package insert, also called the prescribing information. This is the manufacturer's official document approved by the FDA. It lists indications, dosage, contraindications, warnings, and more for that specific drug. Second is Daily Med, which is a free federal database maintained by the National Library of Medicine within the National Institutes of Health. It holds official, up-to-date drug labeling, and because it's current, it's the most trustworthy than an old printed reference. Third, Medline Plus, also from the National Institutes of Health, which gives plain language drug and supplement information. This one is especially useful when you're helping educate a patient because it's written to be understood by the public. Fourth, the United States Pharmacopoeia, or USP, which sets the official standards for the quality, purity, and strength of medications in this country. Here are a few habits to build now. Prefer current online federal sources over outdated print. Match the source to the task, using Medline Plus for patient education and the package insert or Daily Med for clinical detail. And when something doesn't look right on a label or on the chart, stop and verify before acting. Checking a trustworthy source is never a waste of time when patient safety is involved. So, what's your role as an MA when dealing with medications? Everything you do with medications sits on 3 pillars. The first is legal. As a medical assistant, you must work strictly within your state scope of practice. You don't prescribe and you don't diagnose. Those are provider responsibilities outside your scope of practice. What you do is carry out delegated tasks under supervision, and you follow the documentation rules exactly because the medical record is a legal document. Scope of practice does vary state by state, so you are responsible for knowing yours. The second pillar is ethical. This means respecting patient confidentiality at all times, supporting informed consent, and being honest. If a medication error happens or a patient reports a reaction, you report it truthfully. Hiding a mistake endangers the patient and is an ethical breach. Honesty protects people. The third pillar is safety. This is where you'll support the well-known rights of medication safety and provide clear patient education within your role. The single most protective habit is to verify before you act. Confirm the patient, confirm the medication and its generic name, confirm the provider's order, and confirm the patient understands the instructions. When those 3 pillars, legal, ethical, and safety, guide your practice, you become a genuine safeguard in the medication process. You are often the last set of eyes and the clearest voice the patient hears, and the responsibility is exactly why the vocabulary in this lecture matters. In summary, pharmacology is the study of drugs and how they interact with living systems, and for you, it's the working language of patient care. Remember its branches, especially the paired terms, pharmacokinetics, which is what the body does to the drug, and pharmacodynamics, which is what the drug does to the body. Remember that every drug carries 3 names, chemical, generic, and brand, and that charting the generic name is the safest habit because it stays constant and prevents duplicate dosing. Remember the range of effects from the therapeutic effect we want to predictable side effects to more serious adverse reactions to allergic responses that involve the immune system and can be emergencies. Keep the key term pairs straight: dose versus dosage, indication versus contraindication, and potency versus efficacy. Always verify medication information with a trustworthy source such as the package insert, Daily Med, Medline Plus, or USP standards. And above all, practice within the 3 pillars of your role: legal, ethical, and safety by staying inside your scope of practice, being honest, and verifying before you act. In the next lecture, we build directly on this foundation by exploring drug classifications along with their indications and contraindications, so the vocabulary you learned today will pay off immediately. Here are the references used for this lesson.